Hey, welcome to The Explainer. Today, we are tackling a super high-yield topic for your board exams, eating disorders. Now, these conditions can seem complicated, but I promise, once you know the key distinctions, it's actually pretty straightforward. Let's dive right in. All right, let's kick things off with a classic question you're gonna see. You have a patient who is severely restricting what they eat. Your brain might immediately jump to anorexia, but hold on, it could also be bulimia. So, how do you actually tell them apart? This is the central question we need to answer. So here's how we're going to break it all down. First, we'll hit the single most important difference between them. Then, we'll dive deep into what anorexia nervosa looks like, contrast that with the cycle of bulimia, talk about the really dangerous medical problems, and finally, we'll compare how you treat each one. Okay, first up, the core distinction. Seriously, if you only take one thing away from this whole explainer, this is it. It's probably the highest yield point you'll find on your exams for this topic. And here it is. It all comes down to body weight. It's really that straightforward. By definition, patients with anorexia nervosa are underweight. The magic number is a BMI less than 18.5. On the flip side, patients with bulimia nervosa are usually at a normal weight or sometimes even overweight. So when you get that question about restriction, the very first thing you need to ask for is the patient's BMI. All right, so with that huge distinction in mind, body weight, let's dig into anorexia nervosa. This is the clinical profile you need to be able to spot from a mile away on an exam. This number right here, this is everything. A BMI under 18.5 is the absolute non-negotiable criterion. It's the diagnostic anchor that everything else for anorexia nervosa is tied to. Okay, so what's going on here? Well, the psychology is what's driving the physiology. There's this intense, overwhelming fear of gaining weight and a warped perception of their own body. This leads to that severe restriction, which then causes the body's hormonal system to just shut down. You get low GnRH, which leads to low LH and FSH, and the classic result of all that, amenorrhea, or the loss of menstrual periods. And all of that has real, physical consequences you'll see on an exam. The body goes into this extreme conservation mode. The heart slows down, that's bradycardia. Blood pressure drops, hypotension. You might even see something called lanugo. That's that fine, soft hair the body grows to try and stay warm. And of course, you'll see dry, scaly skin. These are classic, testable signs of severe malnutrition. Okay, now let's switch gears and talk about bulimia nervosa. And if anorexia is all about restriction, bulimia is defined by this destructive behavioral cycle. And you've got to know this cycle. It all starts with a binge. We're talking large amounts of food, way more than most people would eat, with this awful feeling of being completely out of control. Then, to try and undo that, they'll engage in what we call inappropriate compensatory behaviors. This could be purging, like vomiting, or non-purging things, like abusing laxatives, or exercising for hours on end. And for it to be a diagnosis, this whole cycle has to happen at least once a week for 3 months. Now, because their weight is often normal, you have to play detective and look for other clues. And these signs of purging, they are super high yield. Repeated vomiting makes the parotid glands swell up. The stomach acid just destroys dental enamel. And Russell's sign, those calluses on the back of the knuckles from inducing vomiting, that's a dead giveaway. On labs, you're going to see low potassium or hypokalemia and a metabolic alkalosis. That's from losing all that potassium and stomach acid. Oh, and a really important distinction here is binge eating disorder. It has the same binge eating episodes you see in bulimia, but, and this is the key difference, there are no compensatory behaviors, no purging, no overexercising, and as you can imagine, this usually leads to weight gain and obesity. All right, let's shift to something incredibly serious. The medical consequences. Understanding these complications isn't just about passing an exam. This is about saving lives in the clinic. So, let's talk about maybe the single most feared complication when you're treating anorexia, refeeding syndrome. This is a life-threatening, full-blown metabolic emergency, and it happens when you try to reintroduce nutrition too quickly to someone who's severely malnourished. The mechanism here is so important to get. Basically, you give glucose to someone who's been starving, and their body releases this huge surge of insulin. That insulin then shoves all the phosphate from the bloodstream into the cells so they can finally make some energy, some ATP. But here's the problem. Their phosphate stores were already rock bottom. The result? Severe, life-threatening hypophosphatemia. No phosphate means no ATP, and that leads directly to cardiac and respiratory failure. It's that serious.
Okay, this table is pure gold for your exams. Let's walk through the key lab differences. For someone with restrictive anorexia, you'll often see hyponatremia because they might be loading up on water to feel full. Creatinine will be low because of muscle wasting. The acid-base status is usually normal. Now for bulimia with purging, remember they're vomiting, so they lose potassium and acid. This gives you the classic triad: hypokalemia, metabolic alkalosis, and a low urine chloride, because the kidneys are desperately trying to hang on to chloride.
Okay, last section. Let's bring it home by looking at how we actually treat these disorders. As you'll see, the game plan is very different for each one. You'll see right away that the approaches are really different for each one. For anorexia nervosa, the absolute #1 priority is nutritional rehabilitation, getting them medically stable, along with psychotherapy. Meds like olanzapine might be used, but they're secondary. For bulimia, it's a combo approach from the get-go: psychotherapy, especially cognitive behavioral therapy, or CBT, plus an SSRI like fluoxetine. And for binge eating disorder, it's similar. CBT is key, and you might use SSRIs or even the stimulant lisdexamfetamine. So, after all of that, what's the one thing you absolutely cannot forget? It's this. For your patient who is severely anorexic, the most dangerous, deadly moment isn't necessarily the starvation itself, it's the refeeding. You have to refeed slowly and monitor phosphate like your life and theirs depends on it. 'Cause it does. Getting that right is way more important than just passing an exam. It's how you save a life.